everyone, and welcome to today's webinar, Stool Antigen Test, a valuable tool for the diagnosis and confirmation of H. pylori eradication. I am Cassie Saltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Diasorin. To learn more, visit www.diasorin.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box to the left and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also use the Ask a Question box to let us know if you're having any trouble seeing or hearing the presentation. I'd like to now welcome our speaker for today's webinar, Dr. Elena Resina Sierra, Assistant Medical Specialist in the Gastroenterology Unit at Hospital University de la Princesa in Madrid. For a complete biography on our speaker, please visit our Biography tab on the top of the screen. Elena, you may now begin your presentation.
Thank you very much. Thank you very much. Good morning, everyone. It is a pleasure for me to be able to give this talk. Today, we are going to talk about the Stool Antigen Test, which is a valuable tool for the diagnosis and confirmation of H. pylori eradication. This is me. I'm doing my doctoral thesis on the diagnosis on H. pylori, and I have worked and collaborated in multiple studies on this bacterium with Dr. Javier Pérez Gisbert and with the European Helicobacter pylori registry. As an introduction, it must be said that Helicobacter pylori is a highly prevalent infection worldwide, affecting approximately 50% of the population. It is the main cause not only of gastritis, but also of peptic ulcer and gastric cancer, MALT and gastric adenocarcinoma. H. pylori screening and eradication is indicated in several clinical contexts. For example, and most common non-investigated dyspepsia, gastric cancer precursor lesions, peptic ulcer disease, MAD lymphoma, naive patients started long-term NSAIDs therapy, and unexplained iron deficiency anemia, and also vitamin B12 deficiency. H. pylori eradication offers the chance of gastric cancer prevention. Antibiotic treatment is recommended regardless of the associated clinical condition. So as you can see, Helicobacter pylori is a problem that affects a lot of people in the world. So now we want to see what the latest Maastricht-Florence guidelines published just a year ago in the 2022 say about H. pylori diagnosis. In first place, they confirm that the test and treat is an appropriate strategy for uninvestigated dyspepsia. They also say that in young dyspeptic patient that with no alarm symptom, non-invasive testing is the one that is recommended. In all other patients, an invasive diagnosis with gastroscopy will be considered. These guidelines remind us that the urea breath test, the UBT, remains an important tool for H. pylori diagnosis. And it also reminds us that the citric acid is an essential component of the protocol. The guides also agrees that the monoclonal SAT, and this is very important for us, the monoclonal SAT, if properly validated, is an appropriate test before and also after Helicobacter pylori treatment. And that diagnostic test used for gastric cancer prevention should preferably be non-invasive. And it's important to say that always we have to discontinue antibiotics 1 month before any diagnostic test, and proton pump inhibitors 14 days before, in order to reduce the false negative results. So as you can see, the non-invasive tests are the main importance in the diagnostic of H. pylori infection. Just to continue, I am gonna make a quick review of the different diagnostic methods of Helicobacter pylori. All H. pylori invasive diagnostic methods are are based on the detection of the organism in the stomach by means of gastric biopsy samples. The first one we're going to talk about is histology. With histology, it diagnoses not only H. pylori, but he evaluates also the gastric mucosa, and we can see also for atrophy, metaplasia, and other features. It is recommended always 2 biopsies of the antrum, 2 of the gastric body, and 1 more biopsy of the incisura. It's following the Sydney protocol. We use normally common stains like hematocin, eosin, also HEMSA that is more affordable, and the more sensitive one, but it's really costly, so we don't usually use this one, is immunohistochemistry, but we usually use hematocin and eosin. Historically, it is the top invasive test with about a 95% of sensibility and nearly 100% of specificity. The second one is the rapid urease test. We have to take at least 2 gastric biopsies, 1 from the antrum and 1 from the body. And we use a medium with urea and pH indicator that change color with H. pylori presence. This method has a sensitivity superior to 90%, and is not a good test for confirming eradication. And we also can see a lot of false negatives in case of bleeding, medium atrophy, and metaplasia. So it has another benefits, as it is a very low cost method, and the diagnosis is really quick. Within minutes or few hours, we have the complete diagnosis. Continue with the invasive diagnostic methods. We have the culture. It is the most specific test. It's always 100% specific, but sensitivity is really lower. We can see between 50 and 75%, so it has a lower sensibility compared to other techniques. It's also very costly, it's slow, and it's technically really complex, so we don't use it very much. When could we use the culture? The main benefit is that it permits to assess antimicrobial susceptibility. So it is important to see resistant or possibly resistant to antibiotics. Continue with the invasive test. We have molecular methods. These methods detect DNA of H. pylori in gastric biopsies, even at low levels of bacterium. It's especially effective during the bleeding, because it has been shown that even with bleeding in the stomach or with blood in the stomach, it's still very accurate. They are gaining very prominence due to about a 95% diagnostic accuracy, and the possibility to identify antibiotic-resistant mutations, especially for clarithromycin. It is recommended now in guidelines, in the previously commented Maastricht latest guidelines, for predicting resistance without the need for culture. But nowadays the availability is limited, so it's not just a routine test. Continue, we have endoscopic imaging. In the recent years, endoscopic have a very good progression in H. pylori infection and gastric cancer precursor lesion. We can use white light or many other filters. They have been obtained in several studies as sensitivity and specificity more than 83% with these different methods. These advances have updated the Kyoto classification, and findings like mucosal nodularity or erythema suggest very strongly H. pylori infection. However, endoscopic imaging is not nowadays a validated diagnostic methods in our countries, in our context. So in this slide, we can see a summary of the characteristic of each invasive diagnostic methods. When should we use each one, and their diagnostic accuracy. Now we will start with the non-invasive diagnostic methods. The first one we will discuss is the urea breath test, the UBT. This method relies on the ability on H. pylori to break down ingested labeled urea, creating 13 carbon labeled carbon dioxide. This isotope, enriched with CO2, enters the blood and is later exhaled with the air. UBT has been the preferred non-invasive option for initial diagnosis and also for eradication testing due to its high sensitivity and specificity that is superior to 19.5. It's close to 100, established through numerous studies and numerous meta-analyses in both adult and children. For example, this Cochrane Library review include 34 studies with 13 carbon labeled CO2. This study obtained a sensitivity superior to 90%, which is really good. And there is a lot of different cutoffs and points, but the most commonly reported threshold is a delta over baseline superior to number 4. We have to remember that the radioactive isotope 14C is not advised for pregnant women and children, so we don't have the tendency to use that isotope, and we always use 13 carbon. UBT has some drawbacks, like all the techniques, but for these methods, patients need to travel to go to the hospital, and it takes at least 30 to 60 minutes. Fasting is required at least 6 to 8 hours, and is expenses for skilled staff, shipping, and lab processing are very high. Also, some groups, like children or disabled population, might have some physical difficulties in performing the test. Now we are start to talking about the stool antigen test. That is the topic of today's talk. SAT is based on the direct identification of the bacterium antigen in stools. There are mainly two types of SAT that we use to identify H. pylori. The first one is MC immunoassay, I make a mistake with the letters, but it's enzyme immunoassay, including ELISA and also CLIA. The second one is speedy in-office test and is immunochromatography assay. The first one, enzyme immunoassay, provides more reliable results than the speedy one or the immunochromatography. We can use either polyclonal or monoclonal antibodies, but monoclonal antibodies-based tests are more accurate than polyclonal one. Therefore, those are the ones recommended by guidelines. Okay. Just to end with the non-invasive diagnostic methods, we are going to speak about serology. The use for initial diagnosis or confirming eradication is not recommended due to the possibility to prolong positive H. pylori antibodies after treatment, even for months or even years. So it's valuable for specific cases when reduces H. pylori density or for epidemiological studies. It is the only method that is unaffected by PPE consumption, but active infection should be confirmed with either UBT or SAT. The determination of antigen-specific immunoglobulins in urine or saliva is not recommended due to the low predictive value. The main technology used for this type of non-invasive diagnostic methods is also ELISA and rapid CART. The last one we're gonna talk about is molecular tests, the PCR. It involves using various types of PCR to extract each pylori DNA from different samples like urine or stool. But by far, stool is the most validated sample with sensitivity for diagnosis around 70 to 80% in some meta-analysis. This method is unique for non-invasive bacterial resistant analysis, and for that reason, it's gaining more and more popularity over the years, with a sensitivity superior to 91 and a specificity superior to 97 in diagnosis of clarithromycin-resistant in feces. In this slide, we can see a summary of characteristics of each non-invasive diagnostic method, when it should be used, each one, and their diagnostic accuracy. As you can see, UVT and SAT are both recommended for your follow-up study. In the following slides, we will discuss several studies and meta-analysis regarding SAT. The first is this is a Canadian review published in 2015. They include studies from 2009 to 2014. It includes only adult patients, and the comparator are either endoscopy or UVT. They includes 21 diagnostic studies, 15 in the pre-treatment, only in pre-treatment, and 6 for the follow-up or post-treatment. In initial diagnosis, we show a sensitivity and specificity values varied substantially depending on the test, on the kit, and the reference standard used. But among the enzyme-like immunoassay-based tests using monoclonal antibody, the sensitivity of those tests range from 90 to 92, so which is makes that a good or a very good diagnosis test, and specificity range from 91 to 100. Rapid test and polyclonal rapid test, or the one we use polyclonal antibodies, were clearly less accurate. So in terms of confirmation or follow-up, they include 5 studies with enzyme-like immunoassay based using monoclonal antibody, and found that the stool antigen tests were accurate and useful tool to determine the results of H. pylori eradication therapy, compared with endoscopy, with principally histopathology with hematocin, eosin, and or urea breath test with a sensitivity and specificity superior to 91. The test based on polyclonal antibodies have also high specificity but low sensitivity, so they are not the preferred one for follow-up. The chromatography-based test using monoclonal antibody surprisingly has also very high performance with sensitivity and specificity superior, more than 90% in the post-treatment setting. The next study I'm going to discuss is this Cochrane library review that I previously mentioned, that include only initial diagnosis, no following up, and no eradication. It includes children and also adults with gastrointestinal symptoms, and the reference standard is only endoscopic biopsy. This review did not accept UVT as reference standard. This review does not discriminate between SAT performed with monoclonal or polyclonal antibodies. In our point of view, is a little bit of a mistake, and it concludes that the UVT is the non-invasive test with the highest diagnostic accuracy, with a sensitivity of 94, assuming a specificity of 90%, and analyzing a total of 34 studies. 21 with 34 studies, with 13 carbon and 21 with 14 carbon. This review also include 29 studies testing SAT with almost 3,000 of participants, and SAT obtained a sensitivity of 83, which is a good diagnostic test, but not the best, because UVT obtained more sensitivity. To continue, we are going to comment this meta-analysis by Dr. Pérez Gisbert. Nowadays it could be a bit old because it was published in the year 2006, and they included studies from the 2000 to 2006 from both adults and children. And the comparator, or the gold standard, was either endoscopy or UVT with carbon 13 urea. For the initial diagnosis, pre-treatment, they included 22 studies with more than 2,000 patients and evaluated monoclonal SAT before the eradication. They obtain a sensitivity and a specificity of 94 and 97 respectively, and a very high positive likelihood ratio, which means this a very good diagnostic test, and a very low negative likelihood ratio, would also indicate that it is a very good or excellent diagnosis method. The accuracy of both monoclonal and polyclonal stool antigen test was evaluated together in 13 pre-treatment students, and higher sensitivity was demonstrated with the monoclonal technique. So once again, is more accurate than the polyclonal one. We have similar results for confirmation. This meta-analysis obtained a sensitivity and a specificity very high, higher than 93%, and a very high and a very low likelihood ratio, positive and negative respectively. So in this confirmation setting, it has still been a good diagnosis test. Both tests were evaluated together in 8 post-treatment studies, and again, the monoclonal technique showed a higher sensitivity. In this slide, we show 2 meta-analyses carried out only in children, only in pediatric population. In the first one, they included 6 studies about monoclonal SAT, and there were no discrimination between pre or post-treatment, which is a little bit tricky, a little bit difficult to obtain results, but they also included 7 studies about the PCR in stool. As you can see in this table, the results with monoclonal SAT were excellent, with a sensitivity and specificity superior to 97%, and also with the stool PCR, they reported a high sensitivity, about 80%, and even higher specificity with 98%. So in the children, they also demonstrate a very good accuracy of the stool antigen test. In the second one, it's a meta-analysis from 2014. They included 45 studies and obtained a sensitivity of 92, a specificity of 94, and a very good likelihood ratios respectively. Subgroup analysis found that sensitivity and specificity were significantly higher when monoclonal H. pylori SAT or 2 or more reference standard methods were used. For the initial diagnosis, as you can see, resulted in blue, they obtained a very good accuracy results, and for confirmation, the results were a a little lower with a specificity were 81%, but with very good specificity close to 98%. So they conclude that the detection of H. pylori antigen in stool with ELISA monoclonal antibodies is a non-invasive, efficient test for the diagnosis of infection in children. However, the available one-step or polyclonal SAT is still nowadays unreliable. This slide, I show you two recent studies regarding the liaison meridian H. pylori stool antigen test. The first one was published a few years ago in 2020 and compared the SAT with a combination of different methods, including histology, culture, and rapid urease test. They included only adult patients, a total of 277 in the pre-treatment group, and only 8 patients in the post-treatment group. In this table, you can see the results. They are excellent, with a sensitivity and specificity superior to 95 and a predictive value, both positive and negative, superior to 92. So are excellent results. And here you are. The second study was published last year, and we are going to talk more in details in the next slides. This study is a prospective comparative multicenter study. 9 Spanish centers participate in it. We included consecutive adult patients with indication of H. pylori infection primary diagnosis or confirmation of the eradication were enrolled between 2019 and 2021. Inclusion criteria were indication to perform an H. pylori infection diagnosis, the capacity and willingness to give written informed consent, and prior prescribed UVT. And for confirmation of eradication, performance of the test should be at least 4 weeks after the treatment was discontinued. Exclusion criteria were the age below 18 years, advances chronic disease that would not allow the patient to complete the follow-up, previous gastric surgery, alcohol or drug abuse, and antibiotic or bismuth salt consumption 4 weeks prior to testing, and PPI intake 2 weeks prior to testing. We finally evaluate 307 patients, and in the figure you can see the study protocol. In the first place, the patient had the UVT, that is the gold standard of this study, and within 24 to 36 hours they have to bring the stool samples. If any tests were equivocal or with unclear results, we should repeat the test again. Fecal samples with discrepant results between UVT and SAT were subjected to 2 different PCRs in external laboratory, just for confirmation of H. pylori present. So the liaison meridian test that was used in the study is a chemoluminescent based immunoassay, a CLIA. It's an automated assay performed on an liaison XL analyzer. In this analyzer, we can also analyze a lot of different things like viruses, a lot of autoimmune diseases. So this analyzer is easy handling of stool samples. We use monoclonal antibodies and clear interpretation. We have a clear interpretation of results based on their index. The time of the first results is 20 minutes, and from then the throughput it's 90 results per hour. So we can analyze a lot of samples within a few hours. We use in this study two different types of UVT technology. On one hand, we use isotope radiomass spectrometry, IRMS, with citric acid solution in the protocol, and negative, unclear, or positive were based on delta values. Negative below 4 per thousand, and positive with a value more than 5 per thousand. And on the other hand, we have the non-dispersive isotope selective infrared spectrometry, NDIRS, without citric acid in their protocol. And we consider the test positive according to manufacturer's instruction with a value superior to 2.5 per thousand. So to perform the PCR in a stool from discordant samples, we use two different genes. The first one is the GLMM gene, and the second one is the 16S RNA region of H. pylori. And to confirm the presence of the absence of H. pylori in fecal samples, the results of both PCRs must be positive or negative, respectively. Here are the baseline characteristics of the included patient. We included 145 in naive or pre-treatment group and 162 in the post-treatment group. 62% of the UVT were carried out with infrared UVT technology, and the prevalence of infection in naive patients was 29%. In the second figure, you can see the results of both SHT and UVT, both globally and in patient pre and post-treatment. In total, 28 of these 307 patients, including 7 false positive and 21 false negative, presented a discordant results between the SHT and the gold standard, the UVT. In this slide, we can see the global results. The liaison meridian had an overall sensitivity of 67% and a specificity of 97%, with a positive and negative predicted values were 86 and 92 respectively. The positive and negative likelihood ratio were 23, which is a very good results, and 0.34. Global accuracy was 91 with an area under the ROC curve of 0.85. In naive or pre-treatment results, we obtain a better result with a sensitivity of 74 and a specificity of 96%. And predicted values around 90%. The area under the ROC was 0.88, but if we analyze the patient who were compared to UVT with mass spectrometry technology, the results were better with an accuracy of with a global accuracy of 93% and an area under the curve superior to 0.90, which is a very good result. Now, the post-treatment results. Patients the results were worse, with a suboptimal sensitivity of 55% and an area under the ROC curve of 7.79. However, it maintains an excellent specificity of 98% and acceptable predicted values with high global accuracy of 92%, as you can see in the slide. As we were commenting, or as I told you before, 28 of all the samples were discordant, and in 3 of these 28 samples, the remaining sample was insufficient for PCR analysis, so we analyzed the rest one, a total of 25. All the stool PCRs were negative for H. pylori DNA detection, So the accuracy of the liaison meridian H. pylori assay was reanalyzing considering all its patients as non-infected. As you can see, the results are excellent, both pre and post-treatment, with an area under the ROC curve of 0.96, which is really good, and in the post-treatment setting, an area under the curve or 0.94, which is also an excellent test in this context, and an overall accuracy of 97. So we have to discuss regarding the comparison between UVT and SAT. 13 carbon UVT is gold standard non-invasive methods, but I could say, or any researcher can say, there is not a perfect gold standard. So we have seen in Resina studies that the infrared technology for the UVT offer a low specificity between 47 and 88 with high rate of false positive. So it is possible that this kind of UVT is not a perfect gold standard because it can have some false positive results. But we see that the SAT is a valid alternative to the UVT because the majority of false negative of the SAT that we obtain in our study, 11 of 15 analyzed with the infrared, were very close or were within these borderline values and close to the cutoff point or threshold point, close to 0.5 per thousand. So liaison meridian H. pylori assay accuracy was inferior in the post-treatment setting, as we just said, than in the naive patient, while maintaining an acceptable post-treatment positive predictive value of 80%, despite a prevalence of H. pylori infection of only 40%. This is consequence of an relative high eradication rate of 86%. So with this scarce prevalence after treatment, the predicted values is still very good. So considering the data after performing the PCR on a stool from discordant sample, excellent accuracy values were also obtained in the post-treatment setting, with a sensitivity of 100%, a specificity of 98%. So the conclusion of this specific study is that the diagnostic accuracy of the SIT for the detection of H. pylori infection is high, with an overall precision of 91% and an area under the ROC curve of 0.85. Despite having a suboptimal sensitivity, its high specificity stands out, and acceptable positive and negative predicted values also stands out. Also, after performing PCR in cases discordant with the gold standard was excellent, which suggests that the accuracy of the technique is higher than initially estimated. The greatest precision of the stool antigen test in this particular study is obtained in the diagnosis of infection in patients who have not received prior H. pylori eradication treatment, and it can be considered a very good diagnostic method in this scenario. So in this last table, we have summarized the advantages of using the SIT as a diagnostic method. For the laboratory manager, it is a fast technique with a high throughput, thus saving a lot of time and a lot of cost. It is easy to handle and automatic, so human error are minimized and the results are fully reproducible for any researcher. For the clinician, it is a safe method that is totally recommended in the guidelines, and it can be used also in the post-treatment setting to confirm infection and only prescribe treatment when necessary. This in order to avoid antimicrobial susceptibility. Oh, sorry, antimicrobial resistance, sorry. And last but not least, for the patient, it is a very comfortable method, as the sample can be delivered with no need to remain in the hospital or in the medical center, thereby reducing work absenteeism. And in addition, there are physical difficulties for certain population, like children or disabled, in perform the UVT. So the SAT is a very good alternative. And it also been like you can use this technique in patient with a distal gastrectomy, in which other techniques like UVT, for example, is not really recommended. So to sum up some general conclusion of the talk, it is necessary to verify eradication of the treatment of H. pylori. Non-invasive tests are preferred for eradication testing. The stool antigen test has proven to be accurate both initial diagnosis and testing for eradication, with elevated sensitivity and specificity superior to 90% and with very optimal predicted values. So due to its multiple advantages that we have just comment, such as comfort for the patient, rapidity, and its lower price, the use of stool antigen test is recommended in context of eradication. Thank you very much for your attention, and I will be happy to answer all the questions you may have.
Thank you, Elena, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just type your question in the Ask a Question box and click Submit. We'll answer as many of your questions as we have time for today. Let's go ahead and get started. Our first question here says, is it always necessary to suspend PPIs? Some patients have some difficulties with the suspension of this therapy in advance for the SAT.
Well, some studies have suggested that for the stool antigen test, it has the same diagnostic values in patient with or without PPIs. But these statements are not widely accepted, and nowadays I would always recommend to suspend PPI. Maybe in the future, with further investigation, we can have more proofs or more studies that say that we can perform SAT without the suspension of PPIs. But nowadays, I recommend the suspension. If the patient is very symptomatic with reflux disease, for example, or another symptoms, I recommend to use ranitidine instead of PPI for 2 weeks, just in order to make to obtain the sample, the feces sample. So yes, nowadays I recommend to suspend PPI.
Great, thank you so much. We have another question here that asks, which diagnostic method is more cost-effective, SAT or UVT?
SAT for sure. This is particularly true since the analyzer, this Excel analyzer, can process a large number of tests per hour. So the price becomes cheaper as the more tests we analyze. In addition, the price of the reagents, it's always lower than the price of urea, and always lower than the collecting bags for UVT. So the costs are always more economic with stool antigen test.
Great, thank you. I see a question in here asking, how can we contact you? So I'm just going to push your email up to be visible while we continue to answer some questions here. All right, next question here. How long should one wait before conducting the SAT after completing antibiotic treatment?
Okay, the always more than 4 weeks. Never less short periods. Some authors propose waiting up to 3 months to reduce the false positive rate if done very early. But in general, I think with 1 or 2 months after finishing the antibiotic treatment, it's the optimal time.
Wonderful, thank you. And it looks like we have time for one more question today. When collecting the sample, does the patient need any advice?
Ideally, the stool should not be very liquid. So if you these days are in a period of diarrhea, I recommend just to wait to a most normal stool to collect them. But if your stool is not liquid but not very solid, we would need a little more of quantity than a solid one. But otherwise, there is no need to make any prior dietary restriction. You can eat a normal diet wherever you are used to eat in a normal day, and there are not any other specification, not other like suspend PPI and antibiotics. So you don't really have to do anything different to collect the sample.
Great. Thank you, Elena. Do you have any final comments for our audience before we go?
No, yes, thank you very much for your attention, and my email is right in the screen, so any more doubts, I will be happy to answer them.
Thank you again, Elena, for your time and your important research. We would also like to thank LabRoots and our sponsor, Diasorin, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.
Goodbye.